Hello, everyone, and welcome to Global Public Health Week 2025, organized by the World Federation of Public Health Association. This annual initiative brings together institutions, communities, and public health leaders from around the world to celebrate the vital role of public health. My name is Michelle Herrera Corbalan, and I'm an intern at the World Federation of Public Health Associations. I will be your moderators for today's session. This webinar is part of Global Public Health Week, which this year carries the important theme Redefining Equity, Decolonizing Public Health for a Healthier World. Global Public Health Week 2025 invites us to reimagine global health strategies through a more inclusive and equitable lens by addressing historical injustices, honoring diverse social and cultural contexts, and placing fairness at the center of public health system. Today's session is titled Investing in Health Equity, the Economics of Pandemic Preparedness. And we are honored to welcome our distinguished guest speaker, Professor Katharina Hauck. Professor Hauck is a professor of health economics and deputy director of the Abdul Latif Jameel Institute for Disease and Emergency Analytics at the School of Public Health in Imperial College London. She is a specialist in the economics of infectious disease and pandemic preparedness. Her research focuses on the social value of health system reliance and uses integrated economic and epidemiological modeling to guide global health policy. Professor Hauck regularly advised the World Health Organization, G20 task forces, and global partners such as CIPA in the Global Fund. She also serves as Associate Director of Health Economics and has led major research projects across low and middle income countries. The session will begin with a presentation followed by interactive Q&A session. Professor Hauck, it is a great honor to have you with us. The floor is yours.
Well, thank you so much, Michelle. It's an absolute honor to be invited here by the Federation to present the work that we are doing at Imperial College on the economics of infectious diseases. So I have prepared a presentation, but I'm very happy to take questions in between. I will talk relatively briefly about and give you more of a broad overview, but I'm very happy to delve in deeper into specific topics if prompted. So really what I want to give you is an economist perspective on infectious diseases. I have been working at the School of Public Health for the past really 10 years now, and working specifically on the economics of infectious diseases. So really what I want to talk about is what is the role of economics in informing public strategies to combat epidemic and endemic infectious diseases. And on purpose, I have dropped the health after the public because I think that policies are more wide-reaching, going beyond the public health sector, that are going to make potentially significant impacts on how we deal with epidemic and endemic infectious diseases. Now, public health and economics sometimes seem to be in a slight disagreement with each other. So when combating epidemic infectious diseases, so outbreaks of a novel or re-emerging pathogen, then what I heard, at least when I joined the School of Public Health, was, well, we combat outbreaks really early and then almost with no regard for costs. And for me, as an economist, or as a health economist specifically, who carefully looks at the cost effectiveness of interventions and compares them against each other with respect to their societal value, this seemed to me quite a strong proposition. But the lesson that I learned for me was that this can make sense, of course, if we can prevent a potentially catastrophic or epidemic or even pandemic from taking hold. So I will talk about this first lesson first and the research that we have done on that. Now, in combating endemic infectious diseases, so diseases that have been around for a long time with us, and where we are really in a position where elimination is difficult, where we are in a position where we basically need to control the disease. Public health experts often say, oh, these preventive interventions, they make sense if they serve us costs later on. But as an economist, of course, I say, well, interventions can be worthwhile, even if they don't save us costs later on. Because really, what are we in for with all of this? We want to evaluate investments into health. That is the important aspect for us. And health is something that has a value in itself. And it's not only about saving costs, it's about improving health. So I will also talk a bit about the research that I have been doing on endemic infectious diseases in order to give you some examples on this kind of work. So really, what is this presentation going to look like? First, I will give you a short recap of economic evaluation, what that is really about. Then I will talk about the cost of epidemic infectious diseases and the cost of our response as well. I will talk a bit about this lesson 1, right? Combating epidemic infectious diseases, and then also how we can improve our response to disease outbreaks by adopting some smart mitigation strategies. And of course, the topic of pandemic prevention and preparedness is also part of this wider group of work. Then lesson 2 is how we combat endemic infectious diseases. I will talk about mainly the cost-effective control of disease. Okay, so what is economic evaluation? What economists are saying, economics is not about costs, of course, as well, about costs, but really it's more broadly, it's about the science of choice. So we have a limited budget and we need to make a decision. Do we want to invest in intervention A or do we want to invest in intervention B? And of course, we have to make that choice because budgets are limited. The goal really of economic evaluations or cost effectiveness analysis, let me put that here, is that we want to identify interventions that raise societal welfare. Now, what is societal welfare? It's first health. For us as public health experts, that is a very important part, that we have healthy populations, and health has an intrinsic value in itself. Societal welfare is also economic gain, of course. It is the value of the investments that we can make into our lives and the general welfare of countries. That is, of course, an important aspect of societal welfare. But then there are also others. And the topic of this talk today is about the reduction of inequalities, which, of course, is a very important additional objective, both on a global level, but also on national levels. Educational outcomes, as we have seen during the pandemic, is something very important as well, with important long-term impacts on health and also economic welfare of countries. And then aspects such as liberties and justice are also and other components that are important for societal welfare. Now, of course, we know that there are trade-offs to be made between these objectives, and sometimes the intervention we implement will place a higher weight on some aspects of societal welfare than of the others. And this is really not a decision by economists, but it is a decision by society, what they consider as most important in this societal welfare function, if you want. So the objective is really to determine the societal value of health interventions under constrained budgets. So usually what we do, we compare the incremental or additional costs and the additional effects, often the benefits, health benefits or others, of a new intervention, and we compare this against a counterfactual. Now, usually the counterfactual is an existing intervention, it's the standard of care, or sometimes also it's doing nothing. So we compare a new intervention against what we do currently, whatever that may be. So it's always about an incremental change in economics, or usually most of the time. And then we need to think about, are these additional effects or benefits worth the additional costs? And usually So usually what economic evaluation does, and many health economists are concerned really with these incremental improvements in healthcare. And when we think about infectious versus non-communicable diseases, often we are thinking about relatively stable or slowly changing disease burden. Yeah, so we have something that is relatively stable in a population, and then we think about incremental improvements in order to make this burden smaller. So really very helpful here in our view on the economics of the problem is this quadrant. And this graph shows us 4 quadrants. And this shows us how new interventions are compared against the existing counterfactual. And when we make that calculation, then we will end up in one of these 4 quadrants. What do these quadrants mean? Let us start with a simple one. So here we have a new intervention that dominates the old intervention, because we have on the horizontal axis the difference in effects, and anything beyond that vertical black line, we have a positive difference in effects. So that means the new intervention dominates the old intervention. We have greater effects. When we look at the vertical axis, this measures the differences in costs. So anything below that horizontal black line means that the costs of the new intervention are lower than the costs of the existing intervention. So here we have a brilliant intervention, because we have one that has greater effects, and on top of that, it also has lower costs. So this is something that really makes total sense to implement, because it makes the world a better place and it saves us money at the same time. An easy case is also when the new intervention is dominated by whatever we have done before or whatever we are doing currently. Because if we are in this quadrant here, in the northwest quadrant, we have higher costs of the new intervention because we are above this vertical line, and we have lower effects, so meaning we have lower health impacts usually. So then we better stick to what we have been doing what we are doing currently, so we stick with the counterfactual, the baseline intervention. Even if this is doing nothing, it's better than adopting the new intervention. Difficult it becomes if we are in the top right quadrant, and this is unfortunately most of the time where we end up when we compare intervention, because the new intervention has greater effects, so it has a greater health, it generates more health, but it also has greater costs, right? So these are the interventions that are associated with positive health outcomes, but they are also more costly than the old intervention. And then is the question, what do we do, right? So then the policymaker needs to decide, are these additional benefits worth the additional costs? And that is something, again, that the health economists can't really decide, but we can lay out the decision problem for the policymaker. Similarly, when an intervention has less effects, but also lower costs, then we are in a decision problem, because of course you might think, oh, it's not great if the new intervention has less costs, but the fact that it has also lower costs means in a way that's a good thing, because we can take away money from this area of public health and invest that money in another area of public health where we may have a greater benefit of that intervention. So these, so the first, if you want, and the third quadrant, they give us a headache, because that is a decision problem that we have to overcome what to do in this situation. Okay, so let us look at the costs of epidemic infectious diseases and the costs of our response. Now, what is our approach really to epidemic infectious diseases? So something that we work on quite a lot at the Jameel Institute is thinking about better response to Ebola virus disease. Just as an example, right? We have the 10th Ebola virus outbreak between 2018-20. We had 3,500 confirmed cases and 2,300 deaths, roughly, right? What did we spend on this? So the costs of the response was more than $1 billion US. And the reason why this is also costly is because, as you see on the right side, this was basically the response team arriving in a remote village where the first cases of Ebola were found and trying to quell this outbreak at the source, associated obviously with very, very high costs. Now, if you compare these 1 billion that we spent on that outbreak, for comparison, in the DRC in 2018, we had 35,000 malaria deaths, and the total spending on malaria was 200 million, much lower than what we spent on Ebola. So if you look at that just as the figures like they are, you might think, as a health economist, okay, is that a good use of our funds? And I will show you that potentially, yes, it is. But let me go to the next slide. We have done some research on that as well. So we have compared the benefits and costs of hypothetical or potentially future Ebola outbreaks were in work led by Gemma. Here at the institute, you can see basically that the under suboptimal response compared to one that is slightly better, more realistic, the costs are really accelerating. Enormous costs, but not many deaths. Okay. But this response, of course, may prevent a catastrophic outbreak that not only spreads within DRC and the wider East African region, but that also could spread into high-income countries. Here you can see the costs of treating one case of Ebola in the US amounted to over 1 million for 2 patients. And this is, of course, because the various infection prevention measures that are adopted in hospitals in high-income countries, unfortunately, leading to very high costs. And that is similar for other countries, by the way. It's not only the US. Okay, so lesson 1, combating epidemic disease outbreaks. Here's some research that has been done by colleagues of mine at the School of Public Health. And this is really looking at the lockdowns against SARS-CoV-2 in the United Kingdom in 2020. So these are model scenarios of alternative lockdown timings at the beginning of the first wave. So that was early in 2020. And you can see here in black, the black line is actual basically, and green is what is modeled. And what is modeled here is what would happen if we would have implemented that lockdown 1 week earlier. And the answer is we would have 23,000 fewer deaths. Now, these colleagues also thought about what would have happened if we would have implemented that lockdown 1 week later. And you can already see with that green curve that this is not going to look very happy, because the additional deaths would have been 84,000, over 84,000. Just 1 week earlier and 1 week later. So clearly reacting early makes sense. Here I show you a picture of the economic impact, or some estimates of the economic impact of COVID-19. These are from the United Nations. And you can see how catastrophic really the output losses were relative to pre-pandemic projections, particularly for least developed countries and small island developing states. The reduction in GDP compared to what we would have expected to happen without the pandemic was catastrophic. But it's not only about economic impact, it's also about the school closures. So apologies for if you can't see that here very well, but I think it gives you an idea that in the 2 countries that are highlighted here, Myanmar and the Philippines, we had long school closures due to COVID. So meaning that these countries mitigated the pandemic really by keeping schools closed. Now, of course, this is not something where you see an immediate financial loss, but we know from research that has been done that such long school closures have catastrophic impact on the future earnings of the children who are affected, and with that, the future GDP of countries that will be impacted by that for decades to come. We have looked at the societal losses that are associated with pandemics. Here, work that is led by Patrick Doohan in my group. He has projected several potential future pandemics informed by past ones, and we can see that the societal losses associated with pandemics are potentially very, very high. If it is a severe disease, such as if it were something severe, such as the influenza 1918 pandemic, and the losses as a percentage of GDP, particularly high in low and middle income countries, less so in high income countries. However, if you look at a more milder disease, like influenza, these costs here in the second row would be much lower, giving some indication of that a massive response or very costly response is not always warranted. And the challenge is to decide when is a serious or very heavy, very costly response necessary, and when is it not. We also have looked at the short to midterm impact of the H5N1 pandemic in US domestic and international dairy markets. Research currently published as a preprint. And of course, that pales now in comparison to the damage that is being done with the tariffs imposed by the administration last week. But still, there is a measurable economic impact of this epidemic that, of course, at the moment is concentrated amongst animals. And here we are looking at cattle. We have also done some research on the long-term economic impacts of pandemics. So here are projections of real consumption per capita after pandemics have ended, 8 historic pandemics, and we can see that there are long-term impacts on consumption that are first increasing and then decreasing consumption that lasts up to 20 years after a pandemic has been done. Again, work that is in preprint and led by my colleagues Seng-Yung Hong and Guillaume Morel. Right. How do we combat then? How do we present these enormously high costs of epidemic infectious diseases? How can we be smart about the mitigation that we do and preserve lives and livelihoods? And how can we better invest into pandemic preparedness? Here's some work we have done on smart lockdown strategies. And essentially the message is by closing first and opening last those economic sectors that contribute much to transmission and little to GDP, and the other way around, of course. By doing that, we can reduce transmission substantially, but the economic hit is not as bad as you would have a lockdown over the whole period of the first year of COVID in the UK. We also look at optimal vaccination. We have also looked at optimal vaccination strategies. So here is an analysis of ring versus geographic vaccination strategies for EVD, for outbreaks of Ebola virus disease. And essentially, we can see that it's not clear actually which strategy dominates the other. Sometimes geographic vaccination dominates, sometimes ring dominates, and we need to make a decision depending on the features of the outbreak and other response, efficacy of other response, which vaccination strategy is the better one. Here we are looking at the projected cost effectiveness of alternative mitigation strategies under, again, a hypothetical influenza 1918 pandemic. This is for lower and lower middle income countries. So here, what you see here basically is a top right quadrant of the cost effectiveness plane that I have showed you previously. So you can see here anything to the right of 0 is greater impacts because it is lower years of life lost, and anything above 0 is higher costs. So what you can see here is that for an influenza 1918 outbreak, if we compare 3 different mitigation strategies, school, economic closures, and elimination against no closures, then it is likely that that for such a severe pandemic, these closure strategies are cost effective. However, you can see that there is great uncertainty around that, and it could be that that is not the case. So it's uncertain whether or not a no closure strategy might be better. So no clear-cut answer here. Where we do have a clear-cut answer, though, is for a milder influenza pandemic like the one we had in '57, where it is clear that the additional benefits of such a strategy are probably of mitigation strategies are probably not justified by the additional costs, and a no closure strategy would be the preferred one. Again, here work by Patrick. We have also helped CEPI to think about the value of the 100-day mission, which is having pandemic vaccines ready within 100 days of an outbreak. This is for a hypothetical SARS-X pandemic. And you can see here that expressed as percentage of global GDP, the value of a significant investment into SARS-specific vaccines, plus in addition having a broadly protective Sabecovirus stockpiled, ranges between 3.4 and 6.7% of GDP. If we have a milder pandemic, and for a more severe pandemic, the benefits would be higher, as here indicated, for the 1 in 100-year pandemic. Right, what are then the lessons from combating epidemic disease outbreaks? What are the lessons really from exponential growth? Well, first, I think it's modeling exponential growth. Growth is much preferable to living it. So thankfully, we have epidemiological modelers who can play through different scenarios for us, and that allows us then, or policymakers, to adopt effective mitigation before the problem takes hold or explodes. We have also seen that lockdowns have massively different impact on deaths depending on when they are implemented. And now the thing is, at similar costs, whether you implement a lockdown 1 week earlier or later, the costs are the same or very virtually similar. The deaths that prevents are very different. So the cost-benefit relation is very, very different whether you implement it earlier or later. Now, economics can inform on smart public health measures. So even if we have a very determined, expensive response, we can still be smart about it and do the things that maximize outcomes at the budget that we have. Economics can also inform on pandemic preparedness. So really, very often when we have interventions against serious emerging or re-emerging infectious diseases, the new intervention very often dominates. So it has greater benefits, but also lower costs, at least if you consider, the knock-on effects and for other countries, spillovers to other countries, and the costs of combating something that has become much larger in size. So this is, of course, then compared to nothing. So that means that even very expensive response can be a very good buy for the world. Now, the thing is different, of course, when we have endemic infectious diseases, so pathogens that have turned for us into a control problem. So where we basically seek to achieve a reasonable balance between infections and the costs for us to responding to it. So very often we are in the top right quadrant. The new intervention has greater effects, but it also has greater costs. So here, economic analysis is really important to fine-tune our control interventions and to make sure that these are cost-effective, i.e. that with the existing budget we are buying interventions of sufficient value. So often the new intervention improves health, but at a cost. So the adoption then depends on our willingness to pay for improvements in health. Now, of course, we know that infectious diseases, endemic infectious diseases, have enormous impact on the economy of countries, on the long-term growth of countries. So here's some preliminary work by Anne Pham from our group, who looked at the impact of malaria on economic development, here measured as total factor productivity, which is basically the efficiency with which workers convert input into output. So it's a measure of productivity of a country. And we can see here that the impact of malaria, of having higher malaria case incidence on total factor productivity is significant. It's greater than the impact of, or similar to the impact of air pollution on the economic development of countries. So what can we do, really? Here I show you some findings from the POPARD study. This is work led by Ranjita Thomas, who is now at the London School of Economics. And this tells us, this was an analysis we did of a combination prevention intervention against HIV. This was implemented in 2 countries, Zambia and South Africa. I show you here the results for Zambia, but South Africa looks actually quite similar. Now, under standard of care, you can see that we have relatively high costs of ART projected for the next 16 years. It was at the time. Now, if we look at the intervention, you can see that's what's added on, right, are the costs of the intervention and the costs of the antiretroviral therapy are not actually going down like people might have hoped, but they're actually going up. And that is because we put more people on the treatment role. Now, my clinical colleagues were quite depressed when they saw this result, but as I said, well, this intervention does not have to be cost saving to be a good intervention, because maybe the benefits we buy with this this only looks at the costs. The benefits we buy in terms of health improvements are so high, then they are justified to make these investments. And then indeed, when we looked at the cost effectiveness of this intervention, we were, if you so want, firmly in the top right quadrant. So we had HIV infections averted, so they had greater benefits, this intervention, but also higher costs compared to the standard of care, and that was in both countries. So what we found was that POPARD in the simulation averted about 22,000 new infections in Zambia, about 10,000 in South Africa, and this cost us about $2,000 per HIV infection averted in Zambia and $3,000 per HIV infection averted in South Africa. And this was by the policymakers considered cost effective. So they made attempts to implement this home-based testing intervention in high prevalence communities. When we look at the how to combat an infectious or outbreak that has reached the endemic stage, like we have with the case with SARS-CoV-2 in the later years, then we can see that when we project alternative start dates and speed of rollout of the vaccine, that the later the rollout happens and the slower the rollout is, the less likely that this is a cost-effective intervention. So although vaccines, of course, are cost-effective very early on in the outbreak, that might be less the case according to the simulation study we did here for Zambia. It might be less the case if they are rolled out too late and if they are rolled out at too slow a speed. And one explanation for this is that there's high levels of infection-acquired immunity in the population after largely two unmitigated waves of infection, as it was the case in Zambia, which reduces the efficacy of the vaccine. Right, so in conclusion, what are interventions against outbreaks of emerging infectious diseases are often very, very good buys, and they improve population health and they save costs. So they are not only cost effective, they are cost saving and dominating other interventions, including doing nothing. So here economics can inform on smart implementation strategies that allow us to maximize the gain for the budget that we have. Now, with endemic diseases, it's a bit more difficult. We have to often, not always, but often we have to do a more careful analysis. They improve population health, but are often also more costly. So here we need to look at what is the willingness to pay of policymakers to invest in health improvement, and that becomes an important consideration. So in closing, I just want to thank our funders, Community Jameel and Kenneth C. Griffin, who are supporting our work on the economics of pandemic preparedness with an initiative launched in 2022. For those of you who like to play through things online, we have recently developed Daedalus Explore, which is a pandemic simulation tool that allows you to play through different hypothetical pandemics informed by past ones under different response strategies and under different levels of global vaccine investment. And you can do that for over 60 countries. Here developed by our very clever software engineers. And what's left for me to do is really to thank the team for the economics of pandemic preparedness initiative here implemented at the Jameel Institute, that consists of epidemiological modelers or mathematicians, economists, macroeconomists, health economists, and we are also working on behavior. So we have a team of behavioral scientists and behavioral economists. So go to our website to get updated with the latest, with our latest work. Thank you so much.
Professor Hauck, thank you very much for your insightful presentation. So let's follow up with the Q&A session. The first question that we have is, how can low and middle income countries finance pandemic preparedness without increasing inequalities?
Yes, that is, of course, a really, really difficult question. So when you remember, I talked about, what is societal welfare, and part of it is health, or a very important component of societal welfare is health. Now, very often we look at aggregate health, population health in the population, and that doesn't tell us anything about how this health is distributed. So there's a very interesting branch now of health economics, which looks at the distributional impacts of economic analyses. So they basically disaggregate the benefits of health interventions for different population subgroups, which can be also, delineated by income. So you would be basically saying, what's the impact of this intervention for low, middle, high income households in a country? And then you can give a higher weight in your evaluation for the low income household. So you basically say, if we manage to improve health in these disadvantaged households, that is worth for us more than improving health in more wealthy, richer households. And that then the whole analysis is then biased towards the interventions that would improve the health of the most disadvantaged. So there are ways of doing that with an economic evaluation. It, of course, requires us to elicit the preferences of a country or of a society for giving up overall aggregate health gain potentially for improving the health of those who are worst off.
Thank you. And we have another questions from the audience. So thanks for the amazing presentation. How can governments from countries at different development stages balance short-term economic pressures with the need for long-term investments in health systems?
Yeah, I mean, there are many aspects, I think, to that question. So let me start with health systems first. It is, of course, we all know about the importance of investing in health systems. Now, the problem with health system investment, as opposed to some vertical investments, is that the investments into health systems benefit a whole range of programs. They benefit HIV care, they benefit TB care, they benefit early childhood interventions, maternity services, vaccination programs against epidemic disease outbreaks. So it's very difficult analytically to make the case for health system investments because the benefits are spread over so many different programs, and this is not how we are set up. So I think it's super important, and there are efforts done in the School of Public Health as well here at Imperial and other organizations and institutions to say, what are the benefits of when you have these multi-morbid populations, what are the benefits of investing in health systems? So I think there's a lot of work to be done in that. Now, with respect to long and short term, of course, for policymakers, their projection horizon may only go until the next election, and that is very unfortunate. Also, the system, of course, is biased towards investments into treatment versus investments into prevention. No one makes any money from it. I mean, or there's much more money to be made with treatment than there is with investing in prevention. So I think it's a role for the public health community and academics working in that field to show the benefits and the costs of prevention in an balanced way. And the need for longer term projection, I think, is clearly there. I mean, sometimes academics or sometimes with our work, researchers are reluctant to project far into the future because there's such a high uncertainty associated with longer term projections. But then not counting these benefits, in my opinion at least, is also problematic. So whatever you do is problematic. So I always err when we project the benefits of prevention intervention, I always err on a longer projection horizon, despite the uncertainty that's associated with this, because otherwise you automatically often bias against prevention interventions.
Thank you. So another question is like, what role can public-private academic partnership play in funding and delivering pandemic preparedness strategies?
Yes, so that's an interesting question. And of course, we have seen a number of public-private partnerships, particularly with the pharmaceutical industry, diagnostics sector. I think it's important to have a fair assessment of the costs and the benefits of these kind of public partnerships for both partners. And yeah, I think it depends on really what kind of specific area you're looking at, but it can be, of course, very worthwhile. We all know the examples of valuable public-private partnerships in public health.
And we have another question. So what one takeaway message will give you for the present students of public health and masters as far as health economics is concerned for a better world with improved health, especially as today is our World Health Day?
Yes, so of course, as a health economist, I'm biased. I would say study health economics, and particular in the climate that we are now, with these potentially dramatic reductions in funding available for global health, I think the importance of economics is even higher. It's the need for making the best investments. I mean, what is likely to happen if now really this is going to continue, that the investments from the US in global health across the different agencies, but also their investments into multilateral agencies, if that falls away, what would be the impact in countries? I think the impact in countries will be that policymakers will be just forced to invest more in treatment because they have the patient standing at the door, and not to provide treatment is so politically damaging and of course terrible in the very immediate short term for population health. So I think there is a danger now that there is a shift from prevention intervention to treatments. So it's even more important to use long-term projections and to use economic analysis to show the benefit of prevention in the mid to longer term. So what I can say to public health students is, yeah, learn about economic evaluation, learn about health economics, but then also if you come from a setting where there is a high prevalence, high burden of infectious diseases, learn how to integrate that with disease transmission modeling so that you can show the benefits and the costs of vaccinations and of other prevention strategies that we know are highly cost effective.
We have another question. It's like, what suggestion for your life as an example to women who want to pursue health economics?
What my suggestion for women who want to pursue health economics? Yes, I think we know that women are still nowadays have a tougher life. It's like it is. We have to prove, we have to be still better to get to the same point as men. But what I can only say is that men, for senior people to mentor junior people and particularly women, I mean, that is so important for me now, and it has been so important for my career as well. So I think sometimes you may be reluctant if you are a young woman in the field of public health to seek the advice of more senior, whether it's men or women, doesn't matter, more senior to help you. But do that, go and come forward and ask for advice, ask for recommendations and for support. We just step forward and do that in your institution, wherever you are based, but also online. And then stick with each other and try to collaborate, be collaborative, be supportive of other women that are facing the same battle with you.
Thank you very much. I think we don't have more questions. Oh, yes, we have one. Thank you for this insightful presentation. I have read your papers on this topic. So the question is, do you think the private sector can play a role in this function combating with epidemics?
Yeah, so I mean, yeah, the thing about the private sector, of course, is that they need to run a business and they need to show a profit to their shareholders. So yes, absolutely. I think if we show and help the private sector to show the benefits of preventive interventions, and here I now mainly think vaccines, I think that's a very important role that we have as well, and to do a fair assessment of the benefits and costs of vaccinations, of investments into vaccinations, but not only R&D, but also manufacturing capacity, supply chains, and vaccine delivery platforms. That is a very important task for public health experts and will demonstrate the benefits of preventive interventions, particularly vaccines.
So Shuyan, he added to the question, as the private sector benefits from this combat, how can we give them an incentive to combat together?
Yes, I mean, yes, I think what Chuyang is alluding to, that of course the private sector benefits from a lot of the subsidies and advanced market commitments and other mechanisms that particularly wealthy countries engage in order to support R&D processes or to support R&D in the pharmaceutical industry. And I think a fair comment is, well, you know, the taxpayer is investing so much in these processes, so and in these investments. So why then is this still a profit-making exercise for pharmaceutical companies? And I think the answer is that public sector organizations who subsidize investments into vaccines and into preventive interventions need to structure well these grants or subsidies or advanced marketing commitments that they make, and basically secure part of the benefits of those as well. Does it answer your question?
We have last questions. So what do you advise for low and middle income countries for epidemics such as polio eradication programs in terms of anti-vaxxer peoples who are not in favor of vaccination their children?
Yes, of course, it is really frustrating for us and makes our public health community very sad to see that people and children particularly are dying because of people's decision not to get vaccinated. And of course, a personal decision to refuse a treatment is down to the personal liberty of a person. But in the case of an infectious disease, this has consequences, of course, for others. So we know that there are effective interventions for people who are vaccine hesitant. And these are, I think, some of the most effective are community engagement, are advised by public health professionals. Direct advice has shown to be effective, and other interventions. We know also that coercive things like vaccine mandates do show benefits. However, there are also some who say it may make the debate more polarized. And then there will be a small percentage of people, unfortunately, who will refuse vaccines, whatever we do. And that is very bad for a disease such as measles, of course, where basically you need to have the whole population vaccinated in order to reach the 95% coverage that is required for control, for effective control or even elimination. But it's very hard to know what to do with these last maybe 3%. I mean, I think some data suggest there might be 3% of people who outright refuse the vaccines.
So thank you very much, Professor Katharina, for your thought-provoking and insightful presentation on the economics of pandemic preparedness. And on behalf of the World Federation of Public Health Associations, we are grateful for your participation and the engaging discussion it has sparked. So this webinar is just the beginning of our global webinar series in health equity and emergency preparedness. So we invite you to continue the journey with us throughout the week as we hear from our standing global health leaders. If you'd like to learn more about our mission at the WFPHA and our work in promoting global health equity, we encourage you to visit our website and follow us on social media. And thank you for joining us today, and we look forward to see you in the next webinar. Thank you very much.
Thank you. It was a pleasure.